Good afternoon and greetings of the day for all the audience who are participating in today's webinar. Today is another series, another second webinar of the series of webinars that we have planned on understanding the trends or the changing trends happening in our audiology practice. As you are all aware of it, it's not just the technology that has changed our practice over a period, but the context, the environmental variables are also influencing our practice. It may be your private practice, it may be an practice in a hospital setup, it may be an academic practice or anything. We are a community practice, community audiology practice. So these changing trends which is happening, we thought that we will try to understand, share the experiences, share some of the innovative ideas that our members are trying it out, which can trigger a new more methods or more better practice or more best practices amongst the group. So in this context, today we have Dr. Heramba Ganapathy as a speaker, who is going to enlighten us on the medical audiology practice part of it, how things have been there, how we are going, how things have been changing, how new things have been coming up in as an audiology practice in a medical setup. I'm sure many of you might be aware of Dr. Ganapathy, but let me just give a brief introduction about him before we start the session, and I hand over the mic to Dr. Ganapathy. Dr. Ganapathy is a graduate from SRMC Chennai and postgraduate from AYJ NHH, and he earned his PhD degree from Ramchandra University in 2015. He started working since then, okay, as both as a teacher and as a clinician. He has a good, almost equal experience of both academic and clinical practices. He has headed few of the programs. He is heading the cochlear implant program, hearing aids, neonatal hearing screening program in a multi-speciality care center, which is attached to their university. He also has been served as a member in the associations for, as leading positions there. He had done some of the projects. He has published. He has good extensive research experiences also. He has been a reviewer of the journal also. But today what we are more interested is to understand his experiences, his thoughts on the medical audiology aspect of it and the changing trends that are happening. So with that brief note, over to Dr. Ganapathy. Please share your thoughts.
Thank you, sir. Thank you for the wonderful introduction. At the outset, I would like to thank ISHA for giving me this opportunity to talk in this webinar. So let me begin. Yeah, so audiology is an ever-changing field. Rather, it's ever expanding. And so do the audiology practices in the medical setup. Around 3,740 ASLPs registered in ISHA. And if you have to know how much they are placed in hospital setup, so there was one survey in 2012, and they found 29.1% of audiologists work in a medical setup, which is the highest. So audiology job in a hospital is something we cannot ignore. Being top of the list, all of us need to know more about it and what are the current practices in it. So there's a growing demand for audiologists in medical setup in almost every year. So Clinical Establishment Act 2012 requires audiology lab for level 3 and 4 hospital. That is, the bigger hospital has to have the audiology lab. The current rules of NABH, National Accreditation Board for Hospital, mandates for an audiometry facility in all the hospitals in India. We know NABH is something which is compulsory for all the hospitals. If they have to have the insurance facilities, if they have to be empaneled, NABH is something that they cannot ignore. So all the hospitals in India will be looking for NABH accreditation. National Medical Commission, which is replacing the Medical Council of India 2020, calls for a minimum requirement of audiometry technician and a speech therapist. However, the medical colleges can have an audiologist if they have an extensive audiological facility to cater to the growing hearing needs of the community. Indian Academy of Pediatrics recommends universal newborn hearing screening in every hospital and advises audiologists to coordinate the program. So with these growing evidences, we can understand the job market for audiology in hospital is booming. While more and more audiologists find their way to a hospital setup, they have to make themselves relevant in all possible ways. So let us see the different kinds of roles that audiologists can play in a medical setup. Let me begin with ENT because they are the most familiar, that all of us know that yes, we'll be working with them. For several decades, audiologists are working in pre and post treatment investigations, but very few work in implant audiology field. So what's new in that? So if you look at the last 10 years, the last decade, more than 20 schemes have been launched to facilitate to continue the cochlear implant program or to start a cochlear implant program in hospitals. So several examples they can say ADIP scheme, TNCMHCHI scheme, Audiology scheme. There are several schemes like that. So in that, I made a rough estimate. In the last 10 years, around 20,000 surgeries have been done of cochlear implant surgeries, I mean. So this has increased the demand for a cochlear implant audiologists like never before. So in order to meet this demand for audiologists, the training is important. So CG fellowship, CG has offered a fellowship for implant audiology 5 years back, 5-6 years back. And then Chandrasekhar Institute Bangalore have started a certificate program in the implant audiology. These are all some of the ways we can empower the existing audiologists to get trained in the implant audiology. So, but what happens? What kind of quality difference this cochlear implant program have created? So, I've been here in the cochlear implant program for the past 16 years. I know my relationship with ENT doctors before and after the cochlear implant program. So, it has tremendously changed. The professional relationship is tremendously changed. It has changed for better. It has changed towards the positive direction. And this program has earned a lot of respect for the audiologists because for the amount of contribution that we can do in the program. And earlier when we started, there was a lot of ambiguity. People were trying to invent their new roles, invent indigenous roles for the hospitals. But later the CG Cochlear Implant Group of India kept on giving guidelines, but the recent guidelines which is given by CG has almost made it unambiguous. So we have at least 80% we are clear that all the audiologists must be clear that what they should do and what they should not do. So this new guidelines is requiring audiologists to possess a master's degree because all the skill levels that is required is it's of higher category, and only a masters who are trained in that level can be able to cater to it. So they must have experience, not only the master's degree, but they should also experience with hearing aid fitting and the cochlear implant treatment. Another area of changes in practice that I want to highlight is the sudden sensory neural hearing loss. Not many people are familiar with how to deal with the sudden sensory neural hearing loss, but then now more and more standards are coming up and more publications are coming. Even the last 10 years, when I just looked at the literature, lots of data are being shared with respect to the practices of sudden sensory neural hearing loss. Audiologists in medical setup have to and must deal and assist with the golden hour treatment for such condition, and they play a vital role in the management. American Academy of Otolaryngology and Head and Neck Surgery has given the following practice guidelines and the role of audiologists in the sudden sensory neural hearing loss. Audiologists must perform the hearing investigation within 14 days of the onset of the symptoms. That's the number one. ABR to be done if MRA contraindicates the retrocochlear pathology. That means if MRA is not highlighting any kind of tumors, then ABR must be done to rule out the tumors, because we have specialized ABR like stacked ABR, which is specifically fine-tuned to detect the smaller tumors as well. So ABR has to be done if MRI contraindicates. And then when it comes to the medical treatment, first 2 weeks corticosteroids is given either orally or intravenously. In first 2 weeks, the improvement is not happening completely. If it is happening only incomplete, or it's not happening at all, then intratympanic steroids will be administered for 2 to 6 weeks. So that is the medical protocol, and audiologists must be aware of this protocol. Follow-up hearing evaluation at the conclusion of the treatment, either at 2 weeks or 6 weeks, wherever it's getting concluded, a conclusion of the treatment, and 6 months of post-treatment also has to be done. One thing I want to caution all of you here is, when I have done the test, we have not seen improvement in all the tests. We have seen improvement in pure audiometry, but then the BERA has not improved. But that's okay. At least in 1 or 2 tests, if you get an improvement, you can be positive about it. And also you should see the patient perception about their own hearing status. So that's very important. And counseling is very important. The reassurance is very important. It's not enough if only the ENT doctor reassures. As a team member, audiologists also must be involved on what kind of words that they have to choose in counseling. Audiological rehabilitation of the residual hearing must be learned. Then comes the pediatrics. So child development program is one of the popular programs in a hospital setup. So pediatrician generally coordinates this program. So they coordinate among the multiple professionals, and the babies who are born with significant birth history are followed up till 3 to 4 years in order to just check whether the developmental aspects are normal or not. So in this program, professionals such as ophthalmologists, speech therapists, audiologists, occupational therapists, physiotherapists evaluate the children in the predetermined schedule. So they'll have the different timelines to test. And when it comes to the audiology, in our hospital, we test up to the 8th month. So all the babies with significant birth history, like hyperbilirubinemia, prematurity, low birth weight, NICU admission, prolongation. So all these, with these risk factors, we test up to 8 months. And if we suspect any kind of problem, we will test again in the year at 1 year of time. And yeah, if there is a problem, we'll start the intervention. But even before the intervention, not only audiologists, all the professionals involved, even before the any kind of a technological intervention is being given, behavioral intervention must be given. So we call it as a pre-stimulation. So pre-stimulation is a must before the amplification is being provided, and then amplification has to be provided, and then we need to verify it. Okay, so let us see the kind of role the audiologist has to play in the pediatric setup, especially in the child development unit. So here we may have to deal with very young infants. So we need, and the child may or may not have the behavioral issue. So we need to develop skills regarding how to test the difficult to test populations, and we need to develop specialized skills, if possible, with the mentorship of some senior audiologists, in how to handle young babies, in terms of electrode placement skills. The knowledge of latency norms below 2 years is very, very important, and marking peaks in morphologically poor waveforms. You may not get how you get it like older children and adults. So it's going to be very poor waveforms, but amidst that, we should develop the skill. We should train our eyes to mark the peaks, and sharing the diagnosis with the family. So diagnosis is very, very easy for an audiologist, but sharing the diagnosis with the family is not. The parents must understand what is the severity of the hearing loss and how the hearing loss is going to impact the child's learning and the development. And on that day of diagnosis, the parent may not understand everything, because they will think that there's something wrong with the child, and everything will go above their head. So probably the audiologist may require more than 1 day, probably 2 days. They have to give an appointment, and they have to complete their counseling about what is the diagnosis and what next to be done. Then assuring audibility. So audiologists must know, for a child is very, very ascertain the audibility. So what happens is, the child, as long as you give a hearing aid which suits the audiogram, our job doesn't end there. So we must ensure the sounds reach the brain. So for example, a simple case, a child may hear every sound, but except that sir sound or sh sounds. So we have to ensure that by giving appropriate intervention, the child is getting access to all kinds of sounds and all kinds of speech sounds. So that is very important in terms of assuring audibility. Arrange for the child to receive appropriate therapy. Yes, this is our job too. We must ensure that what are all the possible therapies available now, and we should tell them that not all kinds of therapy gives equal results, and whichever is available to them, they should be able to take it up as early as possible. And we should tell that improvement with respect to the hearing or time locked. Age matters. So from the time of diagnosis, as the age increases, the prognosis also is going to be delayed. So there is the time locked improvements. We must make them understand, and following up for ongoing evaluation and amplification benefit. At that point of time, we may be perfect with respect to the intervention, but then yes, we need to keep on monitoring the hearing levels. We should call them for multiple speech evaluations, so speech intelligibility evaluation with speech perception test, I mean to say speech perception, and also how the child is benefiting with the amplification. Is the fine tuning of the hearing it is okay? If it is not, then change it. And how the child is performing in therapy. Is the parents aware of what's going on in the therapy? If you ask a question, what kind of goals are being worked on, and the parents say, I don't know, then that means the parents are not involved. If the parents are not involved, we can be assured that the amount of stimulation given at home is also not adequate. So remember, so the child needs stimulation throughout the day and all day. It's important. Even if it is the therapy is being given every day. So in most of the cases, therapy is not given all the days. But even if it is given all the days, it is only 30 minutes to 1 hour. So that is not at all enough for the child. So parents have to be involved in therapy and know what's going on. They have to be involved in the therapy, and that can be a positive sign that the parent is going to give stimulation throughout the day and all day. So these are all some of the roles that audiologists must be aware while working in a pediatrics and in a child development unit. And then it comes to neonatology. So NHS is not new to Indian audiologists, but it is getting a fresh interest recently. So major associations like ISHA, SIG, Audiology Association, Indian Academy of Pediatrics have discussed a national plan in their forums the last decade. In the literature review of NHS practice by Ram Kumar 2017, 90% of NHS outcome in India are reported after the year of 2010. So it is definitely receiving a fresh attention. And most of it is coming from 3 states, Karnataka, Tamil Nadu, and Kerala. So in Tamil Nadu state, there has been a steep increase in NHS practice after 2015, and a sizable interest has been shown by the private sector, because a private sector is showing a lot of interest because the NHS program is able to get a sustainable revenue generated by its own. So this has come out of my own research and my student Mr. Madan. We have done a research and we have found out this particular data. So NHS is considered as a neuro-linguistic emergency testing. Hence, it was recommended to be continued even in the COVID lockdown period with all the necessary precautions. We know if the child is lost the hearing and they lost the ears also, those ears are irreversible. Fine. So what are the key points to remember as a coordinator of the NHS program? The testing personnel need not be an audiologist, but he or she, the audiologist, should enable the testing professional in some 3 or 4 points. So one is definitely you should enable the testing personnel about what kind of technique to be used, how the probe placement has to be done, how to select the tip sizes, and what is the understanding that they have to have about the pass and refer results. So these are all very, very important. So qualification of the person is not so important as a training of the person is. So the training is more important than the qualification. So the second screening refer should always be counseled by the audiologist in order to avoid the anxiety and also to avoid the poor compliance in the poor compliance of the patient in the follow-up. So online database is preferred and follow-up is essential. Audiologists need to continually monitor the program and improve the quality of the program. So for example, in our program, we have introduced a patient satisfaction questionnaire, and we found out that the parents need to have a pre-testing counseling, pre-testing awareness. So about what is this test all about, why we should do. And after that, we introduced that and we used it for a while. So we found out what are all the problems in our program through this patient satisfaction question. And the conference presentation, he should be inclined to share, what is the data or what is the audit of the particular NHS program. and ensure backup screeners and conduct team meetings. This is a must if you want the NHS program to run continuously. We have burnt our fingers in the past that these because lack of backup screeners have stopped the NHS program, have stopped it, and with almost 7-8 months of gap, then again we restarted it. So we have learned a lesson in a hard way. So people can learn it from our own lesson, that they need to have backup screeners and conduct team meetings to make sure everybody is in the same page. The neonatologists, the nurses, the ward technicians, all these people have to be in the same page, and all of them have to be motivated to continue the program. We should experiment to address the perennial issues in the program. For example, we have in our program we have had a problem like the test abandonment. So when we visited the ward for hearing screening in our allotted time, either the child was crying and the child was not cooperative. So we thought that why not try the NHS while the child is getting fed. So and then we did it like a study, and then we got a good success. We were able to test at least more than 90% of the babies while the child get fed from the mothers. So like this, we have to depending on the setup, we need to experiment in dealing with the perennial issues, and who knows, we may get success in some aspects, in some experiments we may not, but we have to keep experimenting it, some new solutions. So these are all some of the points that I want to address as an audiologist when they are coordinating the NHS program. Okay, so audiologists and oncology. So between 2015 and 2025, the number of cancer patients in India is projected to increase from 1.37 to 1.8 million. The significant improvement in oncological treatment have increased the survival rate of cancer patients. However, the treatment has its own side effects. So generally, audiology referral is part of the standard of the care for head and neck cancers. Audiologists aid in assessing the personal risk for hearing loss before, during, and after the treatment. In a significant change, if the significant change is noticed, the best practice is to consult the referring oncologist and refer the patient to an otolaryngologist for medical management. Potentially, we can also tell the information back to oncologists, and they themselves can adapt the therapy plan. That means the drug therapy plan, and then they can ensure that it is not negatively impacting in such a way they can change that it is not negatively impacting the treatment of the primary disease. So that is the kind of coordination that we require. So here, let us see the responsibility of the audiologist in an oncology program. So decision of frequency of evaluation and the type of test to be conducted in consultation with the audiologist. So in our hospital, once in 3 cycles of chemotherapy, we do a hearing evaluation, and then we do OAE and the audiometry. So, but then in each setup, it can differ, but we need to work it out. So in the absence of international standard for ototoxicity monitoring protocol, audiologists have to develop a unique protocol for the concerned medical setup. Though, so we have to work it out with that particular oncologist. There are guidelines given by American Academy of Audiology, ISHA, and WHO. So we can take those guidelines and see whether we can adapt it for the given medical setup. And planning and counseling for audiological rehabilitation in case of unavoidable hearing loss or tinnitus. So we have to do this through various counseling techniques and educational material and a lot of reassurance. Audiology and nephrology, yes, we do have a role in nephrology too. The incidence of sensorineural hearing loss in kidney disorders is from 28 to 77%, and the hearing loss mostly will be in the high frequencies. The kidney and the ear are structurally, functionally, and biologically similar. So conditions that affect one may affect the other too. So it is possible that the genetic disruptions can affect the similar cell structures and fluids of the inner ear and kidney. Patients with CKD, that is chronic kidney disorders, have 1.5 times more chance of developing the sudden hearing loss. So all these things are coming out of the recent literature. So 10 to 15 years, or a lot more is there. Though it is recognized for many years, for the past 10 years, you can see a lot more researches, a lot more data are coming up. So these data are make monitoring of the hearing an important part of the person's healthcare routine. For the many kidney disease medications or autodisease, not just the disorders, but also the medications given to the kidney can be affecting the hearing. It can affect in a negative way. So patients taking kidney medications or treatments thus should be more vigilant to hearing changes. check in more regularly with the audiologists, and speak with the nephrologists about the switching medications if they or their audiologists notice a decline in hearing. So here, let us see the role of an audiologist. So here, I found it very difficult because the nephrologists are not interested to refer patients to an audiologist. But then what happens is I try to set up one-on-one, discussion. So, but if I have to recommend it, so it can either be a one-on-one or it could be a group discussion forums with nephrologists, and initiate a nephro hearing care program by explaining the potential ways of contribution by an audiologist and the need of a mutual support. So what is the best way to do it? To start an initial hearing surveillance study is the best way. According to me, it's the best way. It's because it's the most simple way. So they need evidence to refer patients to you, though they may know it hindsight, but then they need an evidence in that particular setup. So initial surveillance study is a good way to start. So that is where we are in. So we are in the process of starting an initial hearing surveillance study. So to develop a patient education materials of hearing healthcare, including early symptoms of hearing loss. So they may ignore the hearing symptoms because they may be more worried with the primary disease, but we need to educate the patients with the help of the doctors. So we need to either develop a new material, or we can add those information, the already available nephro care education materials. That is the best way. And then to develop the best practice in prevention of hearing problems among these patients. So that's the last point in that. What are the other disciplines? Yes, there are other disciplines like neurology, critical care department. So we know in NIMHANS how Dr. Shivashankar sir has demonstrated to all of us that how he can work closely with the neurology, and how audiology can be more relevant to the neurology, especially in terms of auditory tumors. In critical care department, we have started a noise measurement program, noise measurement thing, and then we have trying to recommend how to bring down the noise levels in the critical care department, because there is a stringent rules in the noise levels that has to be maintained in the critical care ICUs and NICUs. And most of the critical care rooms are not able to meet it because of several reasons. The nurses talking, equipment sound, there are so many sources which produce a lot of noise. So as an audiologist, we can go contribute and measure each levels of noise, and then see and guide them in bringing down the critical noise levels. And then this is the roles with respect to the current one. And then one potential future role that I think that which can come to India is the ceremony management, because we have seen in UK it's already come, audiologists are already doing ceremony management with extra qualification. But yeah, with some amount of push to RCA, I think we can get this role as well, ceremony management, which is a very, very important role. We know in several times in hearing aid fitting, ear impression, sermons always come in the way, and we have to refer only for that reason. We may have to refer it to an ENT doctors, and then it will take some 2 to 3 more days to continue our treatment. Having said all these roles, I want to tell that all these diversified roles are not for a single audiologist. So given a given audiologist can select any or and many roles depending on the following attributes and motivation of him. So we can see there are so many work is there, but of course one person cannot do it. So, but what are the things that will determine who should do what? So attributes and motivation of a medical audiologist. So when will you choose? When will you decide that yes, I have to work with nephrologists? When will you choose yes, I have to work with oncologists? Anyway, I'm working with ENT. The first thing is work passion. Do I get excitement to work with such doctors? Will they take me to a higher level? So are they best in the field? So making sure that no, I am joining with them, will it bring me some kind of joy and excitement? Second thing is remuneration growth in the professional ladder. Not all hospitals, every department will be powerful. So probably an audiologist may think that yes, associating myself in a particular department can help me to get a better remuneration or growth in my professional ladder, my promotion. So this is the second motivation. And third one is interprofessional relationship skills. How well I can maintain my professional relationships. Some people are very good, yes, they can have at a time, they may be very good in maintaining a professional relationship with some 3 or 4 doctors. Some people may not be. So that strongly determines whether you want to expand your role among all these disciplines or not. Then the team building capacity. But see what happens when we start working on it, you may not have this team building capacity. But as the years go by, but once you start in a cochlear implant program, you're already working with 2-3 professionals. But once you gain some experience, that's what happened in my case too. Once I started with cochlear implant program, that boosted my confidence like anything. Yes, I can work with professionals. Yes, they are not above me, just my colleagues. I can talk to them boldly, I can express my thoughts in a nice way. Once I get that confidence, I can look out for other professionals too, like nephrology, oncology. And as the doors open up, I just want to go and capitulate that. And then the fifth one is experience, one of the very important thing. In my early days, when I tried to go and make this kind of link, it was very tough. It was very tough, and they were not able to listen to me. But once, later I understood that you need to have the gray hair on your head. That's very important. Without that, sometimes some things will not work out. So though you are passionate, though you want to do many things, yes, experience matters a lot. And with experience and age only, more doctors will be compliant to your efforts. Then next comes the research potential, which is a presentation and PhD. So whichever the area you get possibilities of doing research, that will give you motivation to work in that area. And the last but not the least, the role models. I have seen people in my own hospital, Professor Rupa Nagarajan. So she has given me inspiration to work with many doctors. So she's such a fluent, she's got a fluent habit of talking to many doctors at a time and setting a professional relationship. I've seen Kalyani Manke madam, I've seen Shivashankar sir. When I see them, they are my role models. So that inspires me to work with more and more doctors. So I think from my perspective, I'm presenting. So these are all some of their, attributes and motivation to be a medical audiologist and to set up relationship with multiple disciplined doctors. So that's also, this is my talk, and thank you. If there are any questions, I'm more than welcome to ask.
Okay, so we have questions in terms of, please elaborate how audiologists and nephrologists, how we play a role in the department of nephrology, more in terms of how we play a role in kidney issues.
Yeah, so I've just shown you some literature that not the kidney disorders are very much linked with the hearing. So that's one of the reasons genetically kidney development and hearing are linked. So any disturbances in kidney can affect the inner ear also. That is number one. And not only that, in severe kidney disorders, we can get to see the inner ear problems. That is one. Second thing is the medications which are given, the diuretics, the loop diuretics are generally given for the kidney disorders or ototoxic. So when it comes to ototoxic, so it can come into the ototoxic management protocol, ototoxic monitoring protocol. Under that also, we are very much linked with the nephrology department, and we have seen a lot of literature coming up, and we ourselves have seen a lot of patients with hearing problems. No, those are either taking treatment or just having a kidney disorder, just having a blood pressure. So having seen that, there is a potential to start a nephro hearing care program. So we do, so there is no dearth of literature. Absolutely, there is no dearth of literature. That is why we need only the cooperation of the nephrologist. So that is where I given you the suggestion that how we can start off. So first you need to have one-on-one discussion with them, showing all the literature and the need for developing a nephro hearing care program. And if they are reluctant, if they are not ready to start off something, then just start a study first. Just do a hearing surveillance first. Do only the audiometry and see how many people are having the hearing problem. Don't take the mild kidney disorders. Say take only the severe kidney disorders and see, is there a link between hearing problem and them, so and such patients, and is there a link between hemodialysis and the hearing. So just do a hearing surveillance, see what is the percentage of hearing problems seen in such people. And once you show an evidence that at least some 10%, 15% problems are there, then they will be more and more convinced to refer patients to you, and then from there onwards you can take on. It could be public education awareness material for specific to the nephrology patients, or it could be early symptoms of hearing loss. So we can have varied things and you can take on from that. So that is where you have to start. So hope I have answered your question.
Yeah, yes. One more thing was, like, in cases like sudden sensory hearing loss and kidney issues and all, the follow-up is very critical. Very important. How do we make sure the patient comes back to your department? How do you link it with the, reception or the departments? How do we do that?
So in terms of follow-up, we have seen it. So the doctor's cooperation is very, very important. If we alone talk to the patients, the complaints is going to be zero. But making sure, the doctors is also asking this question: have you come for it? Have you come for the follow-up? So, or do come for the follow-up. What is the importance of that? So make sure that, as a team, you are counseling the patient. So that is number one. And definitely you need to have a counseling session about what are all the possible effects of this hearing loss. And the more and more you educate, at least even today the patient may not be ready to come to you, but then tomorrow they will be completely ready to come to you, because once the severity of the problem increases, then they will know that there is some kind of help available somewhere. So they will be completely aware that, help is available and I am delaying it deliberately. And once it get to a point of higher severity, so they will come back to you for help. So they will come back to you for help as long as they have enough knowledge, as long as they have enough push given by the doctors, ENT doctors. So sudden sensitivity hearing loss uh, is something we can completely reverse it. That's the most happy news. But what happens is it may not happen also sometimes. So in that case, we have to educate the parent about what are the possible effects of the hearing loss, and help is available. And by giving a varied options available in today's amplification world, I'm sure that even if it's an invisible part of the treatment they want to take, that is possible. So by counseling and taking the help of the doctors and providing the education materials is the best way. And yes, you can take their numbers, you can have your office assistants, we can have the sisters to call and ensure that they give a call and remind them about the follow-up visits. So this is what we do here.
Yeah, and from your experience and from the setup, I see that there's good cooperation between the departments. But there are questions from the audience saying, if the doctors themselves are not recommending or not pushing or not pushing for follow-up, how do we help it? How do we make the situation better?
The only way is educating the doctor. I'm sorry to say that yes, even the doctors need to be educated. Not all the doctors are are literature updated. So what we have to do is, but every doctor wants to publish, every doctor want to be a researcher. That is a different aspect. So whether they are up to date or not, whether everybody wants to do, but you can be a helping hand to them. You can go and talk to them, that you can help them do some research, that you can help them to get a publications. So when this kind of incentives, this is a kind of incentive. So when we tell all these things, so more and more doctors will be inclined to work with you. When they know that you have the ability to write, when they know that you have research interest, that you are ready to work with, then if they have something to get from you, so then then they will try to have a relationship, professional relationship with you. And then over a period of time, if you show some results by publishing, by presenting, and when you can give a kind of data where they can go out and present, where they can publish, there should be some incentives for the doctors. Without the incentives, nothing will work out. So, and then again, I told you, isn't it? So if even if it is not working now, try it tomorrow, try it after a year or so, keep trying. And all these things, what I'm saying is, I have been a terrible failure in the beginning. In the initial 5-6 years, it was a terrible failure, but I kept on telling, kept on looking out for opportunities. And then at one final day, it has happened. You need to have, sometimes you need to have gray hair, but then you don't have to wait till that time. You can start, but one point of time, if you keep on trying and if you keep giving some value based work to the doctors, one final day they will call you and give the patients to you. So that is what I understood from my experience.
So your perseverance paid. Okay, we have one more question, especially insurance cases. It's a little tricky in terms of reporting the diagnosis, reporting it to the particular department, or writing the right diagnostic terms used. You have any experience, any suggestions, any tricks for that?
No, absolutely not. So one thing with respect to insurance is, uh, they have to ensure that the illness started after they started the insurance, after they started paying for the premium. So that's the only thing. But then, yeah, we have made some minimal changes in the reporting in terms of onset of the illness. Onset of illness, yeah. So that is the only experience that I have got. Onset of illness, if you have to try to modify that with help of the doctor. So Other than that, we have not done anything big. So onset of illness have to start after they started paying the premium. So that could be two year or 2 year or 3 year. We have made adjustments in terms of onset. So apart from that, we have not changed anything big with respect to the reporting of the illness.
Okay, there are a few questions in terms of particular cases. Like there's one question about a patient who's having sudden sensory hearing loss. They would like to know how frequently do you call them for follow-up, and which departments you should be associated with to know not to have a drop in the cases.
No, when it comes to the frequency of testing, it should be done first before the treatment, and then after 2 weeks, and then 6 weeks, and then the 6 months post treatment. So this is the frequency the literature is suggesting us. So this is the frequency that we should be going for. And what happens is, mostly whenever I saw a sudden sensory hearing loss, the motivation level was very, very high. It's unfortunate that some people are not motivated. So all the patients, 90% of the patients that I have seen, they're really worried because yesterday they were hearing normally and today they are not able to hear. That has caused a panic, and whenever we call, they've always come. So I've never had any problem with in terms of compliance for a sudden hearing loss. They kept coming, but once they know that their hearing is recovered, they may not come. So that is a hard fact. So you may not able to follow all the protocol throughout, especially 6 months after the onset of the hearing loss. You may not be able to do it at all because they know that they are hearing very well. So once their audiogram improved to mild hearing loss is fine. So normal and mild, they may not perceive the difference. So once it has come to the mild hearing loss or the minimal hearing loss, they are not going to come to you. But at least the treatment worked and it has completely recovered. So only to that extent you can have the data with you. And very, very rarely people, when you counsel them to come after 6 months or so, very rarely people are going to come. But yes, if they come, but then we cannot expect them. But I've seen people with, even after 2-3 months, the BERA has not improved. The audiometry is improved, the BERA is still struggling. The BERA waveforms were not coming up very well, but still, in terms of speech perception, in terms of audibility, the patient improved a lot. And once they feel their confidence is, they have got back, and they are not going to come back to you. But yes, there are some cases where they have not improved. At that time, we have to counsel them for some 2-3 days, prepare them and accept the audiologic management for 2-3 days, and then yes, over the period of time they accept the treatment and they start coming for the treatment. So that is my experience with sudden hearing loss.
Okay, and there's one more question about that insurance thing.
Yeah.
I mean, some audience are asking if there are hospitals where audiology is not covered in the insurance, especially hearing aid consultation and all that. So how do we make that possible? So that,
No.
I mean, once insurance is there, you usually see a rise in caseload. So how do we work around that?
No, even hearing aids are not covered anywhere. So even in my experience, I have never seen any insurance covering the hearing aids. Yes, it has helped us in cochlear implant in some cases, though not many. But inpatient treatment, inpatient, tinnitus treatment. So those kinds of treatment, the insurance has helped, and only the medical treatment it has helped. So even to the medical help, any kind of medical intervention is a prevention of hearing loss. So we assist there. So directly for the hearing treatment, we may not expect the insurance in all the cases. Very few cases only for you can expect it. But then yes, for the medical treatment, they can be get the access for the insurance, and that medical treatment can very much be a primary prevention for the hearing loss. So we have not seen, especially the hearing aids, even cochlear implant for that matter. More recently, only some insurances are covering their cochlear implant, but not many. The hearing aids, zilch. I've never seen any, except for the central government scheme, except for CGHS patients. I have not seen any kind of schemes or insurance covering the hearing aids. So that's a sad thing to tell. Yeah.
Yeah, so we have 2 or 3 of them asking, can you help us in trying to give a kind of roadmap in terms of how to start a vertigo unit in a hospital setup? Whom to approach? How do you start off?
For all there must already be there a vertigo clinic. If you are in a medical setup, the vertigo clinic must already be there. But you just have to go to the ENT doctor and attach or associate your test procedures with them, how you can have a protocol where you can involve a WEMP or a VNG, but you need to get the equipment also for that matter. But you have to show any test that you introduce can generate revenue and support the program by itself. That is the one big question every hospital will be asking you. If you can set up a plan in such a way that the program self-sustains and the equipment cost is recovered in some 2 to 3 years of time with available patient load, so then every management will be interested in starting a program with the cooperation of the ENT doctor. So that is the one most important question they will ask: is the program is revenue generating? Can the program self-sustain itself? So that is one major question that they will be asking for any kind of new program that you want to start. So work out the cost efficiency. In our case, it was never a problem. Being a large tertiary hospital, any program that you start with the help of the doctors is self-sustainable. And most of the programs that I'm talking about, nephrology, ENT, neonatology, pediatrics, everything is self-sustainable, provided you have to give enough care in the beginning, some 2 to 3 months. If you have enough planning and set the program rolling, and you will never regret it. And then once it is revenue generating, everybody will be happy about it and they will appreciate your efforts. That's going to happen for sure.
Okay, and we have, we have few more questions, but before that, I would like to see what Dr. Shankar had commented, or had just left a message. Audiologist role in neurology is challenging both in diagnostic formulation and pre and post surgical intervention. The role has been very well identified in psychiatry also and child psychiatry. And he has a question. Um, can lithotripsy cause hearing loss and should be monitored?
Oh, I'm so sorry, sir. I don't have any experience with that. So sorry. Sorry to say that.
Okay.
Yeah.
Okay. Okay. There are questions like if they, ENT suggests intratympanic injection in sudden sensory hearing loss. Have you seen patients with progress? What is your comment on it? And should we try amplification device? How soon should we try?
That's what, in 6 weeks, till 6 weeks, we should not touch the patient. Till 6 weeks, whatever may be the hearing progress. First 2 weeks is the common medical intervention that everybody will try. First 2 weeks, either it could be oral or intravenous corticosteroids, but mostly they will improve. But if they are not improving, then probably the guideline says they have to make it more stronger treatment has to be given, and not the audiology treatment. More medical treatment has to be given. That can go up to 6 weeks. Once the 6 weeks are completed and then the further improvement is not happening, even then a significant hearing loss is there, only after 6 weeks we should be talking about the audiological treatment. So in that case, yes, everybody will agree. I'm sure that after 6 weeks everybody knows that it is not going to improve further. So ENT doctor will be very much happy to allow us to start our intervention, whether it is a hearing aid or a cochlear implant. So they will give us full freedom to start our intervention per se. So in our case, yes, 6 weeks we have waited and we have fit hearing aid. Some of them have not benefited, and after 3 months of time we had to go for the cochlear implant. So we have done all possible kinds of amplification technology to sudden hearing loss. It is possible. We really don't know who improves and who doesn't. Though they come on time, we can't assure that everybody will improve. So that is a big problem. But I've seen people, different kinds of methodology. Some people straight away start with intravenous uh, steroids, but some people are very happy with oral steroids. Yeah, people take the people will never try the intratympanic steroids. People, ENT doctors, some doctors have gone ahead with intratympanic steroids, but then ENT doctors have multiple types. But then I want to go with guidelines, and I would like to share the guidelines with the ENT doctor whom I'm working with. And at the end of the day, it is his decision to choose what kind of treatment that he's going to progress with. But we have not to touch, audiologist not to touch the patient at least till 6 weeks of time after the onset of illness. So after 6 weeks, we can think about starting the treatment of either hearing aids or the cochlear implant, depending upon the severity of the problem.
Okay. Yeah, I think Imran is here. Imran, are you there? There are a few more questions on the chat. Can you just take it over?
Yes. We can finish the questions, I suppose, if you want. I think there are 3 more I can see. But I just thought, because a lot of questions were being asked around the nephrology part, I mean, especially Dr. Shiv Shankar asked about the lithotripsy. So I just put an answer in. But basically, lithotripsy is nothing but an extracorporeal shock treatment that is given to break down kidney stones. There's a lot of studies done in the 2013 to 2017 period, in Western countries, and they found that it is pretty safe and it does not cause any hearing loss, known hearing loss. But I suppose with what Dr. Ganapathy was talking, I'm quite surprised actually that even in this age and era, 21st century, we still have to convince nephrologists to refer people for hearing referrals with a prevalence study rather than them understanding the physiological dimensions of what nephrological problems would incorporate. For example, like kidney problems like Alport syndrome, you have Fabry's disease, bronchiotorhinal syndrome, things like Alstrom syndrome. These are known causes of hearing loss and kidney problems. Like, people, especially, those people are, like he said, end stage kidney disease. These people mostly would be on, either hemodialysis or kidney replacement therapy. We very well know physiologically and pathophysiologically that they will have some sort of hearing loss. Even like, that CKD thing that he mentioned, most of them will be on hemodialysis. We know that, like people with kidney problems often have hypertension. And he also mentioned about loop diuretics. So these things, like, these are very obvious things. And I'm just wondering, like, why do we have to do a prevalence study? But I understand he's being very humble and upfront about what his experiences are. But it is really surprising to hear that, especially nephrologists in a reputable hospital don't understand the need for hearing treatment. What do you feel about this, Dr. Ganapathy?
So what happened in my experience was, I was waiting for, after in the initial years, I couldn't find some senior nephrologists there. But then after that, I had the privilege of working with some senior nephrologists who worked in a government setup, and then he came and joined our hospital. So he was very much welcome to that idea. So most of the time it depends on the person who's sitting in the chair. So that's more important. So that I suppose many of the audiologists are facing the same kind of problem. It always depends on the person who's sitting in the chair. But what happens is they are answerable to any kind of extra referrals that they make. They have to be completely convinced. So the literature as such, we see not everyone are familiar with. So that is a big problem. And they are not working with an evidence-based approach. So we are the one who have to take in the case when they are not aware, it's audiologists are the one who have to take all the evidence and show and prove both to the nephrologist and to the management. In this case, for a bigger hospital, you have to convince both the people, both the nephrologist and the management. So the evidence-based approach, if we show and if we completely determined about it, I'm sure in few attempts of time, the doors will be open, and then you are going to have patients from the nephrology department. So the study is important. That's what I understood. Though the literature is there, people would like to have their own surveillance report to the management saying that this is a revenue generating program by a referral, by doing a adequate referral or proper on timely referral to the audiology department. So the revenue generating is a must. Second thing is we need to have enough evidence-based literatures which should be shown to the nephrologist and the management, and then I think every door will open. So in our department, this is what happened. We are still in the process. We are getting only the severe infection patients we are getting it, but I suppose we also need to get more referrals than what we're actually getting now.
Thank you so much for that sharing that experience. The other thing also we were wondering, like you mentioned about the pediatric setup that you guys have at the hospital.
Yeah.
I was just curious. So one thing you mentioned that you only test babies up to 8 months if they are on high risk. But then you mentioned about the neonatal hearing screening as well. So I'm just wondering, are we only testing neonates who are at high risk, or are we testing absolutely every newborn? Or where do you stand right now?
No, what happens is we have a slightly different newborn hearing screening protocol. If there are no risk factors, we don't follow them up. Absolutely not. And then there are some medical risk factors and non-medical risk factors. So generally what happens is we counsel all of them to come by 8 months, though it's not compulsory. We don't have any hold of such people who are having a non-medical risk factors. For example, it could be a family history or consanguinity. Nobody, since it's not a medical risk factor, they don't come under the child development unit. But as an audiologist, we tell them that there is risk factor and you may have to come back. But when it comes to the child development unit, more than one doctor is looking at the child and they are under complete control over the child. They will be continuously taking some kind of treatment with the doctors. So we are having complete hold of such patients. So whatever we say, the compliance is 100%. So we test up to 8 months, and if there is no abnormality in hearing, we stop and we just educate the parent regarding the auditory milestone, then we leave them. But in 8 months, if we get some kind of suspicion, we continue our testing even up to the 2 years. For example, 1 or 2 risk factors, we anyway follow them up to 2 years. It could be a torch infection or CMV infection. Only then we extend our surveillance to a broader number of age, with a larger number of age. Otherwise, we stop our evaluation at 8 months and don't get any suspicion, we stop it. And then only with suspicion we extend it. But those speech evaluation, speech follow-up happens to till 2 to 3 years of age. We have the same department as speech and hearing, so we do get patients, but at any point of time the speech suspects a hearing problem, they do refer to us. But then as such, the protocol for hearing stops at 8th month. We do a behavioral evaluation, VRA and a BERA. If that is convincingly normal, then we stop at that point of time, educating the parents regarding the normal auditory milestones. So that is what we do with respect to the newborn hearing screening and KCT, and child development unit.
Sure, that's interesting, because in Australia we obviously screen every single child who's born, but I suppose what you are trying to get at is the population is not high.
No, sorry. What I meant to say is, in terms of newborn hearing screening, we test all. It's universal, but we don't follow all of them at around 8 months of time. Though we counsel them to come back at 8th month for all the risk factor babies, they don't. If they come for refer to the first screening, second screening, and diagnostic evaluation, that itself is a big thing. There itself, we are having 50% loss to follow up. Only 50% of the baby come back. They don't have any hold because they don't have any other medical problems. So we don't have any hold of such people to make them come back, at the stipulated time. But when it comes to child development unit, they are already having some kind of medical problems. They are already visiting the doctor. So there is a very good catch for us among such patients. So they do come up to 2 or 3 years for speech. For audiology, stop at 8 months. But newborn hearing screening, it is universal, no doubt about it.
Thanks for clarifying that.
Yeah, thank you.
I think there is some questions about the sudden sensory neural hearing loss as well, Dr. Ganapathy. I think questions around, like you mentioned rightly, there's a set protocol that you guys follow about, how corticosteroids and intratympanic injections and all that should be tried. So the questions are more around, like, at what stage do you give up, and at what stage do you start rehabilitation and amplification sort of procedure? What is your experience on that?
Yeah, that's what I said. Giving up is only the medical decision. The doctor have to say, yes, I'm stopping the steroids now and you take over. But there is a general guideline, the timeline. If you take a timeline, it's 6 weeks of time. That's the general timeline that we look at. But yes, doctors may slightly, 1 or 2 weeks of plus or minus can be there. But the general guideline is up to 6 weeks. We don't touch the auditory rehabilitation till 6 weeks of time. After that, yes, with the approval of the medical doctors, we start our intervention. We know that after that, It's no way that the patient is going to be improving with respect to the hearing. And then all the audiological tests are confirming the hearing loss, and depending on the hearing loss, we start the amplification strategies, whether it's an implant or yeah. So we have done both. The cochlear implant also we have done hearing aids also. But the problem is, in some patients, we have had a negative experience that even speech perception was a problem. With a lesser degree of hearing loss, the speech perception also was a problem. So, and then what we have to do is provide hearing aids, teach all of them the communication strategies as well, and then assisted listening device. So we had to give not one technology but multiple technologies to help them communicate in a better way. So that one negative experience I do have, but then yeah, 2-3 patients we have given the hearing aids and they are doing quite well. And then yes, one patient with implant who has not benefited at all with hearing aids, and they are also doing very well with the cochlear implant. So yeah, but not many. So I can recall some 5-6 patients overall. Yeah, but and then other patients we have lost to follow up. It's 5 or 6 more patients lost to follow. We only believe that they have made a complete recovery. I only think positively that they have made a complete recovery, and that's why they have not come. We should know that not all improvement happens only because of steroids. It could be a natural recovery also. It could be a spontaneous recovery also. But yes, there is an element of better chance of recovery with steroids. So yeah, if the patients are not turning up, there is one possibility that they have recovered. That's also possible. Yeah.
Thank you so much for clarifying that, Dr. Ganapathy. As a side note, by the way, we've had a lot of success with hyperbaric oxygen therapy in Cairns.
Okay. That's great.
I actually saw about 15 patients in the last, say, 7-8 years who've actually improved with hyperbaric oxygen therapy. We are fortunate enough to have that facility here. So after the protocol that you mentioned of corticosteroids and intratympanic steroids, they actually go for hyperbaric oxygen therapy, and I've actually found 15 people actually improving their hearing quite significantly. So that's definitely something that I feel maybe should be also considered, but of course it depends on the availability as well.
That's right. That's good.
There's not a lot of questions, Dr. Ganapathy. I can see. Okay, there's one more about endocrinology, role of endocrinology in audiology. Like, what do you think? How does that work about? Have you explored that area much?
Absolutely not. I'm the endocrinology. I'm sorry, I have not worked with them. Though I know that I read some literature about endocrinology, but then I don't have any personal experience of working with endocrinologist. Neither I've heard of someone working with endocrinologist. Yeah, I would be happy to know if anyone can share about it. Yeah.
Thank you so much, Dr. Ganapathy, for such a wonderful talk. And being really honest and upfront about your practice does definitely open a sort of a curiosity amongst a lot of our new grads about how hospitals set up and audiology work and all that. And of course, you've shared your long-term experience as well of how you've gone about things. So definitely helpful for people who may want to start up hospital practice. Great talk. Definitely, I'm sure we all enjoyed it.
Thank you.
Thank you, Dr. Ganapathy.
Thank you.
Shall
we sign off then?
Yeah, thank you all. We can close the session.
Yeah, thank you for giving me the opportunity. Thank you so much.